In this video we will study the anatomy of spleen, the largest lymphoid organ of the human immune system and also a major hematopoietic organ annexed to the venous drainage of the gut. We will start with an introduction to the spleen, providing its major functions, immunological and hematological, as an important host for the reticuloendothelial system. Following that, we will proceed to the descriptive anatomy of the spleen, focusing on its situation, orientation and dimensions, very useful anatomical features for the clinical assessment of the spleen. Next, we will take a closer look at the structure of the spleen typical of lymphoid organs. We will, then, enumerate the supports of the spleen as peritoneal relations as well as the visceral relations that each part of it establishes as a junctional organ between thorax, retroperitoneum and peritoneal compartments. Afterwards, we will proceed to describe the blood and nerve supply and lymph drainage of the spleen before summarizing. The spleen, the largest of the lymphoid organs, is situated in the left hypochondrium. Although it is not part of the alimentary tract, it drains to the portal venous system. It constitutes a blood container that has a major role in hematopoiesis and immunity. The spleen lies under the diaphragm between the 9th and 11th ribs on the left side of the abdomen at the left margin of the lesser sac. Being developed in the dorsal mesogastrium, the spleen projects into the greater sac surrounded by peritoneum of the original left leaf of the dorsal mesogastrium. Its hilum lies in the angle between the stomach and left kidney. Its long axis lies along the line of the 10th rib, and its lower pole does not normally project any further forward than the midaxillary line. If the spleen enlarges, its long axis extends down and forwards along the 10th rib in the direction of the umbilicus, and its anterior border approaches the costal margin to the left of the greater curvature of the stomach. A kidney enlarging downwards does so in the direction of the iliac fossa. The spleen is 12 cm long, 7 cm wide and 4 cm thick. It weighs 17 grams in the child and 200 grams in the adult. Its weight decreases in the elderly. The measurements quoted are average. The size of the spleen varies considerably. The spleen must at least double its normal size before its anterior border passes beyond the left costal margin. A palpable spleen is identified by the notch in its anterior border. In some diseases the spleen is grossly enlarged and may extend across the upper abdomen to far beyond the umbilicus. Whatever the degree of enlargement, the spleen glides in contact with the diaphragm and anterior abdominal wall in front of the splenic flexure, which remains anchored to the lower pole of the left kidney, and no colonic resonance is found on percussion over the organ. Retroperitoneal tumors, such as the left kidney, do not displace the overlying colon and they are crossed by a band of colonic resonance, a further diagnostic point. The spleen is prismatic in shape and contains two faces, two borders and two ends. Its diaphragmatic surface is molded into a reciprocal convexity of the diaphragm. Its visceral surface contains the hilum and is in contact with the stomach, the left kidney, and the left colic flexure, each of which impresses a concavity alongside the attached splenic vessels. Its long axis is rather anteroposterior alongside the 10th rib and, thus, defines the upper and lower borders and the anterior and posterior ends of the spleen. To identify the surfaces of the detached spleen, hold the convexity of the organ, its diaphragmatic surface, in the hollow of the left hand. Rotate it until the notched anterior border lies to the front, near the thumb. The concavity behind the notched anterior border is the gastric impression. It leads back to the low prominence of the hilum. Behind the hilum is the concave renal surface, while at the lower pole, at the tip of the little finger of the left hand, is the small colic impression. Let's now have a much closer look and figure out what the microscope has to say about the spleen. The lymphoid follicles of the spleen, which collectively form its white pulp, are scattered among the sinusoids or red pulp. The splenic follicles have a unique identifying feature. An arteriole courses through them, near but not through their germinal centers. Of course, in random histological sections not every follicle will be cut in a plane that displays the arteriole, but when seen it is pathognomonic of spleen, which also has a thick connective tissue capsule with trabecule extending inwards from it below the serous coat. T cells are found in the immediate periarteriolar region of the follicle, with B cells in the germinal center and other parts. As the closest derivative of the gut to the dorsal mesogastrium, the spleen has several peritoneal folds that are rather means of compartmentalization of the left part of the abdomen than of supports. Indeed, its visceral peritoneum, or serous coat, invests all surfaces, gastric, diaphragmatic, colic and renal, and at the hilum comes into contact with the right leaf of the greater omentum. The two leaves of the greater omentum, now in contact, pass from the hilum forwards to the greater curvature of the stomach, the gastrosplenic ligament, and backwards to the front of the left kidney, the linorenal ligament. The peritoneal attachment at the hilum of the spleen extends down towards the lower pole, and this attachment makes a ridge in the greater omentum. This attachment can easily be torn, accidentally, during splenectomy. The hilum of the spleen makes contact with the tail of the pancreas, which lies within the linorenal ligament. Now, let's go step by step through the parietal and visceral relations of the spleen that, practically, mold its shape. The diaphragmatic surface of the spleen is covered by the diaphragm. Through the latter, it is overlaid by the left pleura and lung and the 9th to 11th ribs. This surface of the liver can be damaged during thoracic trauma. Its visceral surface is segmented into 3 small concave surfaces by a horizontal fissure ending in a delta at the bottom, the hilum, where the visceral peritoneum reflects and the spleen receives the splenic vessels and nerves. The gastric surface is the impression of the fundus of stomach. It is suprahilar and is attached to the greater curvature of stomach by the gastrosplenic ligament. The renal impression is infrahilar and posterior and is attached to the anterior surface of the kidney by the linorenal ligament. The colic impression is infrahilar and anterior and is attached through the colic flexure to the diaphragm by the phrenicocolic ligament. Its upper border is recognized by its notch below the anterior abdominal wall of the left hypochondrium and separates the diaphragmatic surface from the gastric impression. Its lower border separates the diaphragmatic surface from the renal impression between the diaphragm and the upper part of the lateral border of the left kidney. It is spread out and rather lateral and coincides with the colic impression. It is rounded and stands in the level of T12 vertebra. The spleen projects towards the midclavicular and midaxillary lines sagittally and the 9th and 11th ribs transversally. The spleen is supplied by a 5 mm thick tortuous artery, the splenic or lenal artery. The splenic artery is the left terminal branch of the celiac trunk. It may arise, exceptionally, from the aorta or the superior mesenteric artery. It passes inside the retropancreatic fascia of Treats alongside the upper border of the pancreas behind the body and then in front of the tail between the 2 layers of the linorenal ligament and ends 2 cm from the hilum, dividing in a T-shaped or Y-shaped manner. Usually, further branching gives rise to 4 segments, perhaps only 2 or 3. Intersegmental vessels are small and scanty. The splenic artery gives rise to pancreatic arteries supplying the body and tail and anastomosing with the circles of the head, short gastric arteries and the left gastropiploic artery participating to the arterial circle of the greater curvature. The veins of the spleen drain the sinusoids of the red pulp, accompany the arteries and unite to form the splenic vein. The splenic vein flows into the portal vein beneath the lower border of the splenic artery, first, in front of the tail of the pancreas, then, behind the body and inside the retropancreatic fascia, afterwards, over and in front of the left renal vein and the origin of the superior mesenteric artery. It ends within the superior mesenteric vein at an angle of 75 to 130 degrees. At this point, its diameter reaches 10 mm. The splenic vein drains the short gastric veins, the left gastropiploic vein, the pancreatic veins and the inferior mesenteric vein. Lymph drains into several nodes lying at the hilum and thence, by way of the retropancreatic nodes, to the celiac nodes. The spleen is supplied from the celiac plexus with sympathetic fibers only. For future surgeons, removal of the spleen, known as splenectomy, essentially involves cutting its two pedicles, the lienorenal and gastrosplenic ligaments. In an emergency after rupture with hemorrhage, the left or posterior layer of the lienorenal ligament is incised and the spleen turned medially so that the splenic vessels can be dissected away from the tail of the pancreas and ligated arteries before veins. The short gastric vessels and the gastrosplenic ligament are then divided and removal completed. For an elective procedure, it is usual to enter the lesser sac by dividing the gastrosplenic ligament and its vessels and then to deal with the splenic vessels and the lienorenal ligament. The stomach must not be perforated when ligating the short gastric vessels, and damage to the tail of the pancreas and splenic flexure of the colon must be avoided. In a nutshell, the spleen is a left recess of the portal venous drainage. Its implications in clinical medicine are numerous. It may concern the obstruction of the portal drainage behind splenomegaly and dilatation of portosystemic anastomosis. It has, also, a major immunological function that requires the use of prophylactic means against infections after splenectomy. Moreover, as a hematopoietic factory, the spleen may be concerned by some abnormalities of hematopoiesis responsible for anemia.